So we are on live, so we are good to go now.
Okay, thank you. Hello, doctors. Welcome to this experience sharing program on managing PPH case studies from labor room. Today we have got Honorable Speaker Dr. Romika Kapoor with us. This program is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993. We have got 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FTFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Experience Sharing Program on Managing PPH. As I said, we have got Honorable Speaker Dr. Romika Kapoor with us. Dr. Romika Kapoor is MBBS MS on Obstetrics and Gynecology, currently in Malti Hospital, Bhopal, member of Indian Menopausal Society and FOXY member, specialized in infertility, adolescent health and menopausal health, have 25 years of experience and has done MBBS from Bhopal and MS from Areva. Active participation in NGOs, women's clubs, social awareness activities, organizing health clubs and free health checkups. With this brief introduction, I hand over the session to Dr. Romika Kapoor. Over to you, madam.
Thank you, Prashantji. Namaskar. Thank you so much for such a lovely introduction. And today we all are here to discuss about the role of carbetocin in PPH. Every gynecologist is scared of the fact that the patient should not turn up into PPH. Now we all know that basically PPH is a increased blood loss during delivery, and it can extend up to 24 hours from the time the patient delivers, causes hypovolemia, tachycardia, and also leads to unnecessary blood loss leading to anemia. So, in the conventional, if we talk about the what is PPH basically, we all know that it is divided into three severities. The mild PPH would be your blood loss is roughly 500 ml to 1000 ml. The second, which is mild to moderate, would be a blood flow of more than 1000 to 1500, and a severe variety where more than 1500 ml of blood is lost, leading to other hematological complications and definitely a maternal morbidity also. So, postpartum hemorrhage is always preventable. So, what can we do to prevent? How do we select the cases? What medicines to give prophylactically or for treatment? That is what we will be discussing. And a lot of times it's really unfortunate that we land up with PPH where there is plenty of blood loss leading to maternal morbidities. And hence came the role of newer uterotonic medicines. We all were very well aware of oxytocin, which was previously used and is still currently also used both in augmentation of labor and also for the treatment in PPH, etc. So, if we see what are the clinical findings when a patient lands up in PPH, we all know that it causes a circulatory collapse, which can cause an increase in the abdominal girth. The uterus, sometimes, if it's a atonic PPH, leads to increase in the size of the abdominal girth. There is reduction in the tone of the uterine musculature, causing maternal tachycardia and definitely uncontrolled bleeding, which leads to a panic in the obstetrician. Now, when we diagnose the PPH and we assess the patient, then we should be very quick right from the start when the patient starts, bleeding, or we feel that yes, we have identified what is the type of PPH which we are dealing with. Now, if you see the first type of PPH would be when the patient has atonic PPH, when the uterine musculature is unable to contract. This can lead to a hypovolemic shock also. Hence, as we generally put a parenteral line, we should try to infuse the patient with proper crystalloids, if needed, colloids also, and keep the blood ready. The coagulation profile is again a very important tricky factor which can play a role in a coagulopathy related PPH. The third can be a traumatic PPH due to, injury either to a vasculature during a cesarean delivery, or it can also be due to trauma to the vaginal bed when you deliver vaginally. So identifying the cause of PPH is really important to, to secure the bleeders properly and then go ahead with the uterotonic additions. So, Dr. Prashant, can we have the slides? I'm not sure whether I'm audible to everybody or not.
You are audible, madam. Absolutely audible.
Okay.
Yeah.
Okay, fine. So now if we see the role of a uterotonic agent is really important about when should we administer the uterotonic agent. Now there are various theories. Some give it when the head is crowning, some give it when the anterior shoulder is delivered, sometimes by the end of the second stage, and in some patients we give when the delivery of the placenta has occurred. Now there's another set of patients in which we give prophylactic preventives to prevent PPH if there's been a past history of PPH in her last pregnancy or delivery. And secondly, when we know that the patient has chances of having PPH like a big size baby more than 3.5, 3.6 kgs. Secondly, also in twin deliveries and in polyhydramnios. The therapeutic use also again depends upon the management and how we are going to decide the next step. Now, the new drug that is carbetocin is definitely a revolutionary medicine which we have been using for the past 3 years. And Dr. Prashant, it is pretty surprising that one of our anesthetist was the one who started and introduced this molecule to us. And
Okay.
for the past 3 years, so Dr. Sheila Chincholkar and, was somehow not available today, but definitely I will pass on her insights to all of you during my talk today. So basically, carbetocin is also, we have tried to replace it lot many places with oxytocin. The reason is that it is a synthetic and a long acting analog of oxytocin itself. So the mechanism of action basically is that it tries to prevent uterine atony, and it is administered as a single shot injection of 100 micrograms, that is it's in a vial of 1 ml. Generally we dilute it in distilled water and then we give over a period of 1 minute. So pharmacology also of carbetocin, it has a prolonged half life as we compare it to oxytocin, and hence the enzymatic degradation also is gradually reduced by this. So, if we come to what is the efficacy of carbetocin as we compare it with oxytocin, so we found that since internationally, and there have been lot many randomized double blind studies which have shown that carbetocin is more heat stable as compared to oxytocin, and therefore when we use it for the third stage of labor, especially in periphery health centers where sometimes the cold chain cannot be maintained properly, so it is a boon for such places because then we can definitely minimize the blood loss by about 500 ml to 1000 ml by timely intervention, especially during vaginal births also. Now, even if we compare oxytocin and carbetocin in respects to the efficacy, then definitely what I have also found by using it that is faster acting, and the uterotonic effect also lasts slightly longer as compared to oxytocin given alone. So today I think I would like to share few of my cases with all of you because the pharmacology and rest of the things are available online for all the doctors to see. That I used it in three different categories of patient. First was a normal delivery. So my patient had come in a spontaneous labor. She was an anemic patient. Her hemoglobin was 8 grams. And in spite of us trying to give her a proper iron supplementation, we were not able to increase her hemoglobin levels. So, on the crowning of the head for this patient, since it was a normal vaginal delivery, I was going for a ventouse assisted delivery. We gave her carbetocin, and luckily for us, her blood loss was very minimal. The normal, it was roughly less than 500 ml only. And her hemodynamics was very stable, because that patient was, because she was anemic, she was in labor, she was already tachycardic. And surprisingly, since her heart rate was nearly 110, 120, after giving carbetocin also, my anesthetist noted that her hemodynamics was very stable. We could maintain her pulse rate in accordance with her delivery time. So I was expecting her to be, become slightly tachycardic, which was not there. So I think I was very relaxed when she delivered. The blood loss was minimal, the uterus contraction was very fast, and I was able to attain that in, say, about within 1 minute's time also. So I was happy with this patient. Second case was a case of a cesarean elective delivery of a 38 weeker second gravida. Her first cesarean was because of polyhydramnios and a big size baby, and the same thing was there in this pregnancy. Hence, we were mentally prepared that she might land up in PPH, because that was her history in the past pregnancy. She was also given 2 units of blood transfusion post her delivery. So, with her, we gave her a prophylactic dose of carbetocin as soon as I, delivered the head of the baby. And this time, surprisingly, the patient did not have any PPH at all. It was a very nominal kind of a bleeding which occurred. And other than that, this patient also had a very good post cesarean, per vaginal blood loss. And overall, I was really very happy by using carbetocin for her. Now, my third case, of which I will talk, was of a patient I delivered about 3 to 4 days back. She was a RH negative pregnancy with a hemoglobin of 10 grams. And she was a full term patient with a big size baby. Hence, I took her for a elective cesarean. And as we all know, we obstetricians generally are slightly, careful when we take RH negative patients, because we are not very sure as to when we can land up in PPH because of any reasons. So, although I had counseled her husband and we had to use carbetocin, that was for sure. So, we gave her carbetocin, and in this patient also, luckily, we did not have any PPH. We had a very good tone of the uterus post giving carbetocin. The uterus retracted very fast. The blood loss again was very minimal. The patient was very hemodynamically stable. The main side effects which we used to face while giving oxytocin was that one thing was that we had to give very high doses of oxytocin ampules. So here I think it becomes very less messy if you do not have too many hands to support you, or your nursing staff is busy somewhere. It hardly requires a single shot of injection. So with this RH negative patient also, I had a very good experience by adding carbetocin. So that is how I would like to advise that whenever we gynecologists and obstetricians are planning a delivery, or we either go for a normal or for a cesarean delivery, or a elective cesarean for that matter, and when the patient are coming to us in the antenatal period, it's very important and always good to map out what negative and positive features are there in the history of the patient, especially past histories, her present hemodynamic situations, her blood profile, her coagulation profile. And I feel history taking definitely is very important, because then we are able to isolate the cases accordingly and be prepared for any eventuality.
Thank
So,
you so
any
much, madam.
question?
Yes, thank you
Ji,
so much. There's some
ji,
questions. I
ji,
mean, I'll just
Prashant ji.
run through it.
Sure.
If we use carbetocin as a first-line drug to prevent PPH, what is the actual
Ji.
benefit to the patient?
Yeah, I feel the actual benefit definitely is your saving out on blood loss.
Yeah,
So
correct.
nothing more valuable than the
Yeah,
blood.
absolutely. And in India, the patients
And
are
I think
anemic
for
to begin
every
with.
doctor, yes. So
Yes,
I think that it becomes a very panic-ridden situation in the OT or
absolutely.
the LR labor room. So I think our first and foremost goal should be to minimize blood loss,
Absolutely.
because these days we are having lot many patients, especially in the tertiary setups, who are high risk patients. elderly
Correct.
patients, elderly primees, IVF pregnancies. And these days we're not having five, seven kids. Generally, the
Yeah, yeah,
couples are
yeah.
having one or two children.
Absolutely.
And their experience in the hospital and, their reaction, because they are coming for a very happy moment. So I think
Absolutely. Yeah.
the doctor should be cautious so
Encourage.
as to ensure that the patient delivers safely with minimal blood loss. So I think that is one very important factor with
But
carbetocin, which
many patients have metabolic syndrome to add to that, with elderly
yes,
people.
true.
Yes, yes,
So
yes.
diabetics are there. We have
Correct.
so many, thyroid patients, heart disease patients. So n
Yes.
number, basically, I think all high risk patients
Madam,
should
in
be.
our country, one of the worst things is that patients don't share their personal history, their past history.
So that's what
That's
I'm
one of the,
telling. It's the
yes,
role
that's
of the doctors and your
absolute.
assistants that your
Yes, correct.
history taking should there be no loophole in your history taking.
Correct, correct, very correct. At least we can save the word patient problem. I mean, we have already answered this, anticipate PPH. I suppose anemia is a major cause, must be in our country.
I'm so sorry, I couldn't get your voice, Dr. Prashant.
The one of the major cause which can precipitate PPH. Anemia could be one of them.
See, anemia is definitely because India is a leading
Yes.
leader in anemic pregnant females.
If we go
And,
take hemoglobin,
so yes, definitely it's like
yes.
garibi mein geela aata, matlab already your hemoglobin is low. And then you again, so you again have more blood loss. So I think
Correct, correct.
somewhere we have to break the cycle since the hemoglobin is less. Definitely, a lot of hemoglobinopathies are also there, like thalassemia, sickle cell. So I think if we minimize the blood loss, you are actually cutting that whole vicious cycle at one particular point. So that cascade of those
Correct.
unfortunate, misfortunate incidents actually stops.
Stops. Right. I mean, you have already shared your experience with RH negative mothers. I mean, you
Ji,
had a
ji, ji.
patient, yeah, live experience. Madam,
Yes.
generally doctors use oxytocin for labor induction. Can they use
Ji.
carbetocin for prevention?
Yes, prevention ke liye to yes, because see, generally oxytocin is definitely if you're not, and it's actually is more about awareness. So
Correct.
I think once you start using the molecule as prophylaxis, also that's what I was telling. Ki prophylaxis is prevention is always better than cure. So
Yeah, yeah, yeah,
even
very
we
correct.
believe strongly in prophylaxis, be it for vaccination of cancers, like you
Very
have
correct.
HPV vaccination
Correct,
to
correct.
prevent cervical cancer. It's such a huge burden in India. So our second largest cancer in women is cervical cancer, and now we've introduced HPV vaccine. So we are
Vaccine.
advocating use of the vaccine. Similarly, that's what I was telling. If you know what kind of patient you are dealing with, so always better to know your enemy before going to the war. So I feel that going for a delivery is actually a war-like situation, a
That is
battle
correct. That is
where the
correct. Yeah,
doctor always has to come out as a winner.
yeah,
So
yeah.
one should always, try to prevent. So in prophylaxis, if you know you are, anyhow, we either used to give methargin, we used to give pitocin or oxytocin for that matter. So we are already giving some of the other uterotonic post delivery. So if possible, so once you start using the molecule, you will gain more and more confidence, and you'll also start to know in what majority vast cases we are able to use it and what result you were able to get.
Yeah, and our own experience always helps us to
Yes, that
further
that that
welcome.
is the main thing always.
And madam, you generally prefer IV route or IM route?
No IV route. That's what
IV.
I told you. My anesthetist generally advises a IV route, which is given that 100 micrograms जो आपका आता है 1 ml, we dissolve it to 10 ml of distilled water and give it slowly over a period of
1
1
minute.
minute.
But
So
I
that
suppose
is better. In some
I
patients, there can be anaphylactic reaction, so
yeah,
always better to give in a dose where you can withdraw it
correct.
timely.
IM route I suppose will be more preferred in peripheral settings where they do not have any help, where they do not
Yes,
have support.
definitely. That is true. So if
In our
not
country, yeah,
available,
yeah, yeah, yeah.
yes, if you're understaffed, you don't have, then you can give a IM route,
I'm
because we can give oxytocin, as I told you, right from the crowning of the head to the delivery of the anterior shoulder to the delivery of the placenta.
yeah,
So
correct,
in
correct.
case you are short staffed, you can very well give a intramuscular and let your assistant come and help you out with the rest of the delivery process also.
Absolutely. And your experience, how well it is tolerated, any adverse effects?
That what I was telling ki if the actually generally we are worried tachycardia होता है तो obstetricians को लगता है कहीं bleed कर रहा है कुछ हो रहा है. So hemodynamically what
Yeah,
I
it's
found
true.
was one of the USPs of carbetocin is that the patient remains very hemodynamically stable, and it is very effective. I think since so many years we've been using, hardly 1% of the cases were one which did not respond, which can be true for any molecule.
That is
I have
correct.
not seen a reaction to the molecule as such till date, but it was ineffective in about
That
five to
will
six
always going to
cases,
happen.
which can be. So we had to,
Exactly.
add on misoprostol in such cases and methargin in 2 or 3 cases. I had to do that, but in rest of the patients, as I mentioned, we had really good results.
Very good. In fact, this is a condition where the condition itself is bad, and having a drug with side effects will be further bad.
Yes, true.
And you already answered this. If a patient is not responding adequately, what other uterotonics? You already said prostaglandins, methergine.
Yes, so we can give methargin and
Yeah,
prostaglandin that really help.
helps. And advantages or other uterotonics, apart from storage, of course.
Because see, storage is one, as I told you, the cold chain maintenance
Storage.
sometimes is not possible. And even if
Very
it
good.
is there in the cold chain, there are chances there might have been a bridge, a gap in
Yes,
the
yes, yes.
cold chain. So
Power
one thing is
outage.
it's hemodynamically stable, and then the effect is faster and it remains for a longer period of time.
Very
Just say
correct.
previously, when about 4 5 years back, when we had such kind of patient, we had to give a cocktail of all things.
Oh,
We had
yes.
to start 30 units, 40 units of pitocin. Also, we had to give methargin. Besides, methargin and prostrodin used to have lot of GI side effects,
Correct.
nausea, vomiting, loose motion. So the table used to get soiled. Patient used to, pass motion. So I think all those process have reduced now quite a lot. And so I think that way this is better.
And as you said, there are golden moments. These side effects are a little disturbing.
Yes, it
Yes.
is because then
Yes.
अभी आप नीचे साफ कराओगे कि patient
Correct.
bleed
Correct.
कर रही, so I don't want my patient to be pouring from all the
Correct.
holes of
Correct.
the body.
Correct. Yeah.
So she's vomiting, she's passing stool, and she's bleeding from the vagina. So I feel
Very
that
good.
to keep it very crisp and clear, and main thing is the vitals of the patient. Pulse, BP remain maintained, one good factor. And
Correct.
so I'm relaxed from that point of view. I concentrate only on delivering the baby, and all the smiles we see after the baby is delivered.
Yes, really. I mean, it should be how you use that firstly. Overall, madam, your experience, take home message to the audience.
So I think take home message for all the doctors when the audience would be that do your homework properly, isolate cases which are high risk, take the history properly to know if there has been any mishap or an incidence of PPH in the past. Please do the coagulation profiles, her bleeding clotting time. In case you have a patient who is anemic, who has Rh negative blood group, somebody who is polyhydramnios, diabetic. So keep your plan B also ready. Please do not rely only on one medicine just because we're dealing and talking about the molecule. Doesn't mean you can land up in other things. Always rule out other causes of PPH. Always atony is not the cause. Sometimes we
Correct.
leave
Correct.
bleeders, sometimes the coagulation profile is altered, and there are n number of things, so one has to think and work like Durga ji, having so many hands, and the mind also has to rush here and there. And I think start using the molecule. Once you start using it, you'll realize that it is very much superior to the older ones which we have been using in the past.
Very correct. Very correct. Madam, thank you so much because your experience will further help doctors to have confidence in the drug rather than
Yes,
reading
that is
papers.
true. Yes,
Yes.
yes.
Thank you so much
And
for
thank you so
sharing.
much, Dr. Prashant, for moderating the session
Madam, thank
wonderfully
you
with
so much.
me.
Thank you. Thank you. It
Okay.
was a pleasure listening to your cases, especially the cases where anesthetist was also involved and
Yes,
hemodynamic. Because
so
this
yes,
will
so
give a lot of
next time
confidence
when
to
we
the
think
doctors to
she's
know.
Dr. Sheila
Yes.
Chincholkar, she's a
Ah,
very
ah, ah.
senior anesthetist and
Okay.
basically a obstetric anesthetist.
Anesthetist.
So she was the one who introduced this, and since she's there, so half we are also relaxed that she's taking
Absolutely.
care of that
Absolutely.
part.
Absolutely. Absolutely. It's a teamwork
So
finally.
it's a teamwork,
Yes.
definitely. Yes, yes. Okay,
Thanks so much.
Prashant.
Yes.
Namaskar.
Yeah, namaskar. Thanks all the doctors who
Namaskar.
took time from their busy schedule and attended this. Thank you, IT team of Hetero. Thank you, sales and marketing for coordination. Thank you so much, madam. You can log off. Wish you a very pleasant afternoon.
Thank you so much, Prashant.
Yeah.
Thank you.
Thanks, Bhuvan. Thanks, Balaji.
Thank you, sir.